Hey guys, welcome to Mr. Nurse Prep. Today we're going to be going to our second video in the cardiology series discussing CAD, which is another acronym that stands for Coronary Artery Disease. As per our usual format, we're going to be talking about some background, which is where we're going to start, where we discuss the anatomical processes that are being affected by this disease. We're going to talk about what's wrong, which is the pathophysiology of coronary artery disease. We're going to discuss who is going to get it, which is your at-risk patient populations. How do you know they have it is our signs and symptoms and our lab values, our diagnostics. How to fix it is going to be the nursing interventions, pharmacology, and procedures. And what could get worse is going to be the worst case scenario that could occur with the disease process, the really dangerous things that occur with coronary artery disease. So with that, let's get into it. So to describe some background, I've given two different scenarios here for us to look at. You have truck A and you have truck B. And both these trucks are trying to deliver their cargo to the factory at the end of the road. And I want you to ask yourself, which truck is going to get to the factory sooner? A or B? If you look at the road for truck A, it's fairly smooth, no major blockages, nothing that's going to make it stop. Looks like it's going to get there pretty quickly, assuming there's no, divine intervention by God, meteors falling out of the sky, things of that nature, right? In a normal circumstance, truck A will very easily and effectively deliver its cargo to the factory. Truck B looks like it has a speed bump in front of it. That is my attempt at a stop sign. And yeah, I guess there's been an earthquake near the end of the road causing a lot of difficulty. The factory looks like it was affected as well in this earthquake. So truck B is probably going to have a harder time getting its cargo to the factory, right? And that's going to be a problem for the long term, for production, for these people who are waiting for whatever's in the factory, right? For whatever normal processes the factory has to do, a delay in getting the services from the truck is going to cause some problems. And your body works the same way, right? If you watch the heart failure video, you'll understand that your heart is really important because it's supplying your body with blood by pumping it out. That's what the heart functions as, a pump for all the blood in your body. And that blood is important because it's carrying oxygen and nutrients and everything your body needs to continue, being your body. So when there's a smooth road for that blood to be delivered on, it's a good thing for your body. There's no issues, production goes on as normal, everyone's happy. All the people, all the organs and tissues that are waiting for oxygen and nutrients are getting it in a timely fashion. They're not being overworked, and therefore the process goes on smoothly and as it should. But when the pathways that oxygen is being delivered to your body through have stop signs and road bumps and blockages, then oxygen delivery and therefore, delivery of everything else, delivery of blood in its essence is delayed, and that causes problems. So to understand this a little more clearly, we're going to have to take a look at the anatomy of your blood vessels, because there are blood vessels in your body, but the really important thing that we're talking about in coronary artery disease is the blood vessels that actually supply your heart with blood, because your heart is a muscle. Your heart needs blood just like the rest of your body does, and it has its own blood supply and its own blood vessels. The blood that it's receiving from the body through the superior and inferior vena cava are going into the heart, but your heart has its own vessels on top of it that are supplying it with blood and therefore with oxygen so that it can continue doing its job. So you can see how if one of those blood vessels had some blockages in it and oxygen delivery was impaired, then that would be a whole lot of problems, because we know that your heart's really important because your whole body kind of relies on it. So we're going to take a look at that. So To understand coronary artery disease, we have to understand the anatomy of your blood vessels. So we have an expertly drawn example of blood vessels right here. And there's 3 different layers to your blood vessel that you need to understand when talking about this, and then a few other things that are going on. So this layer right here, this layer that is in direct contact with the blood, that is called the tunica intima, and that's because it's very intimate with your blood. It's in direct contact with it. Now, the section that lies in the middle, so we'll call that this area, right here, they all start with tunica, so you can understand that. That's the tunica media. And the tunica media is the muscular section of the blood vessel, which lies in the middle between the tunica intima and the outer layer, which is the tunica adventitia. That's how I would say it. So that's the outer covering. So intima, media, adventitia. It's 3 layers of a blood vessel. Now the inner circumference, which I've tried drawing here, is referred to as the lumen. And the lumen is the area that your blood has to flow through. It's the available, circumference that blood has available to it for travel. So obviously a lumen that is clear is optimal because it allows the most blood to go through and the most oxygen to go through. But if the lumen is decreased, if it's clamped down on the sides by a buildup of plaque, things like that, then less blood is able to move through. And if less blood is moving through, that means less oxygen is getting through, which means that, because these are blood vessels that supply the heart, that the heart is suffering and having to resort to methods of producing energy without oxygen, which means it has to switch from aerobic methods to anaerobic methods. And your body's not designed to be anaerobic. We are beings that are meant to use oxygen. So that produces damage and lets your heart release various signs and symptoms telling you, hey, something's wrong. I'm not getting enough oxygen. So we won't go super into depth with this because coronary circulation is something that can get very detailed and very complicated. There's various degrees of practice where you should understand more of this, or I guess you could argue less of this. And when you start to look at things like acute chest syndrome and myocardial infarctions or heart attacks, understanding the coronary artery circulation is very important. For coronary artery disease, we're just going to give a basic, this is more like a nice to know scenario. My nursing program didn't specifically ask questions on this. Your nursing program might. I think it's good to have a basic understanding of it. So, understanding where the coronary circulation is going and what it's affecting is important. As you can see, here, let's see if you can see this little cross thing. You have the superior vena cava here supplying blood into the right atrium. You have your aorta here, which is pumping blood out. You have your pulmonary arteries here, right? That's all very common and familiar to us. Now, this branch of coronary circulation right here is called the RCA, or the right coronary artery. Easy enough. And then over here, you have the LCA. Guess what that stands for? Left coronary artery. Great. Easy going so far. Gets a little confusing after that. So the RCA breaks off and forms the right marginal artery, which is kind of this little branch off here. And then this portion of it that wraps around the backside of the heart, that is called the posterior descending artery, or your PDA, okay? So then the LCA goes down and has another situation where there's a portion of it that breaks off around the side, as you can see by these black lines. It's supposed to be like on the other side of the heart. But that is the CX, or the circumflex artery. And then this big one right here is the left anterior descending artery, or the LAD. So the LAD gives blood to the front and bottom portion, and you can kind of see in the anatomy here, of the left ventricle and the anterior portion of the septum. The septum being, the portion in the middle of the heart, right? The circumflex artery is responsible for delivering blood to the left atrium and the posterior and side areas of the left ventricle. So if an infarct occurs in one of these areas, you're going to see a deficit in the corresponding portion of the heart. Wherever the blockage is occurring, that's where you're going to see, we're talking more in the case of like an MI, it's where you're going to see the effects is distal to the portion of the injury, right? So the LAD is usually regarded as the most important artery on the heart because it supplies blood mainly to the left ventricle. And if it's blocked, then that's a big issue because that left ventricle is super important. It's pumping blood out to the entire body. So a near complete or complete blockage of the LAD is often referred to as a widowmaker. And, I don't think I need to go into really intense detail explaining why. Survivability of it is not great. So that's why it's earned that very affectionate nickname. So if you hear someone say they had a widowmaker, or a patient's, having a widowmaker heart attack, then that's because there's a severe blockage in the left anterior descending artery. So again, real basic coronary circulation. These are the blood vessels that we're talking about in this chapter. These are the blood vessels that are being affected and that are having decreased blood flow. And you can see why that's not good, because then the ability of the heart itself is being impaired, which is super dangerous. So now that we kind of understand what's going on in coronary artery disease and why it's so dangerous and what's really important about it, we're going to talk about what's wrong, which is the pathophysiology of the condition. So coronary artery disease is a type of, I always mess this up, arteriosclerosis, or you could say that arteriosclerosis is the main cause of it, So what happens is you have a blood vessel here, right? And fatty deposits are going down into the blood vessel and are hardening over time. So you have, for example, lipids, which will make these, because like fat is orange. If you've ever like cooked a really good dish and put it in the refrigerator and then like you go to pull it out and there's all that like orange looking fat on top of it, so that's why we're using this color. But so this is fat, and you have HDL and LDL, and your LDL is your less desirable lipids, and they are less desirable because they are more dense. So what happens is they float down to the bottom, and over time they begin to deposit down here, So here you're like, oh, you have a little bit of, that you still got a pretty clear lumen, right? All is well, just a little bit of some fat in your arteries, right? Well, there's a 3-part development that occurs as a result of this, because when the lipids are being deposited in the intima of the artery, remember, that causes damage. So that damage can be caused by hyperlipidemia, but it could also be like diabetes or toxins or hypertension. But after it damages something called so here we'll write this out. You have damage, and then you have a fatty streak, kind of a not so nice name. But so then a fatty streak forms on top of this, right? So lipids are in the fatty streak accumulating and starting to migrate into the smooth muscle cells. So if the fatty streak is continuing to develop, then a fibrous plaque can form and begin to actually change the structure of like the arterial wall. So basically all this is just saying like this thing is getting bigger, you know? So after the fatty streak, you have a fibrous plaque. So the ability of your blood vessel to repair itself is getting lost because it's getting super clogged, and it's beginning to harden up the walls of the artery because the walls of the artery themselves are actually being changed. Then collagen covers the fatty streak that was there, and after that it's just a super narrowed blood vessel, right? It doesn't even matter, right? We'll cover all those blood cells. It's just a mountain of not good, you know? So the danger with this is twofold. One, as you can see, less blood, blood had this whole area to travel through, and now blood only has this area to travel through. So decreased perfusion is occurring, and if decreased perfusion is occurring, then decreased, your heart's not getting enough oxygen, and that's causing damage, right? And what can happen is after that collagen gets laid down, so we'll write that out, collagen, a complicated lesion can form where the plaque grows so large that it can actually ulcerate or rupture. And if that happens, so if this is to explode and rupture, then it's going to activate your body's clotting process, and basically a giant clot is going to form. This is going to be, it's just a mess, isn't it? And if that happens, then that's total blockage of this coronary artery. Nothing's getting through here, nada, zilch. And if that occurs, then it's really bad situation. That's when you're having like an MI, you know? So it's a slow burn, right? You have, I'll actually write rupture and clotting. You got 6 steps to get there. This takes time. This doesn't happen, overnight. This takes years of having high cholesterol and not treating it, and other things that make you more at risk, which we'll talk about in a second. But it's a complicated process, For nursing, you might not need to go this in depth into it, but I think it's helpful to understand exactly what's occurring, where you're having this cholesterol and these lipids build up in your coronary arteries. You have that fatty streak leading to a fibrous plaque. Collagen covers it, and a complicated lesion can form, which can eventually rupture. And if it does, then that clotting cascade can fire off, blocking the entire artery, which is super dangerous. So there's also another concept that's important for us to understand when we're talking about what's wrong in coronary artery disease, and that's something called collateral circulation. So collateral circulation is what happens when you're having this buildup of plaque inside of your arteries. Your body's smart enough to realize that something is wrong and that oxygen delivery is being impaired. And it's kind of giving you a chance to survive this, in that sense. So this is a normal artery right here. You can see my cross. And it's pretty clear. There's no fat anywhere, no buildup of plaque. And you see that you have these branches off of this other like microcirculation, and that's clear as well. But it's not really like connecting anywhere out. It's just kind of branching out, So, and also, some of this is limited by my drawing abilities, but you understand that you got a clear pathway, so this circulation is not very built up, right? But then in here you have some plaque development, and you can see that as the blood flow is impaired here because the lumen is much smaller, it's all being funneled into this one area. instead of having this giant area over here, that the circulation off to the side has been built up, right? It's developed more, and it's led to alternate pathways. So now blood can go through here as opposed to just through here, which is better than only having one narrow pathway. And you can see that eventually, if there is like really, really bad disease, that what I try to demonstrate here, again, I'm not the best artist on the planet, but is that it's actually become thicker and almost the same size as the original circulatory path that blood was following. So basically your body will almost develop new circulatory patterns in response to this blockage that occurs with coronary artery disease. So there's an important concept to understand, that those who have had a longer time for collateral circulation to develop usually have a better chance of survival. So this is something that occurs over time as well, as long as, also the coronary artery disease occurs over time. This isn't just an instantaneous process, but it's your body's way of coping and maintaining homeostasis in light of this. All right, so here we have our section on who is going to get it, and that's those who are at risk for developing coronary artery disease. And the people who are at risk can be broken down into two different categories. One is those who have modifiable risk factors, and then there's those who have non-modifiable risk factors. In actual clinical practice, obviously there's some crossover between the two of these. Some people have non-modifiable risk factors and then increase their risk by taking on modifiable risk factors. So a lot of your points for nursing education are going to come in from the modifiable risk factors. But also you can educate people who have non-modifiable risk factors that they are at risk simply because they are who they are, which is not fair, but true. So starting with the modifiable, things that make you more at risk for developing coronary artery disease are smoking. Smoking puts you at risk for just about everything you can think of. Smoking causes endothelial damage, which, as we know, can be like a prerequisite. That first stage in the development of coronary artery disease is number one is damage, right? Smoking usually like the number one thing. If there's a test question, it's like, what is the number one modifiable risk factor the patients should stop? It's usually smoking. The other is a poor diet. A poor diet can lead to increased LDL. Remember, so there's HDL and there's LDL. And the acronym that I use is, and I was taught in nursing school, is that HDL is highly desirable lipids, LDL is less desirable lipids. And the LDL are less desirable because they sink to the bottom of your artery and start to clog it. Also, diets high in triglycerides as well. Those can put you at risk for developing coronary artery disease. So like the standard lab values for cholesterol for a healthy person, you want it to be less than 200. LDL is supposed to be less than 130. HDL, you actually want it to be greater than 60. And triglycerides, you want it to be less than 150. Those are some values that are probably pretty good to memorize. Elevations in cholesterol, LDL, and triglycerides will put you more at risk for coronary artery disease, and as well as a decrease in HDL. I will say from my clinical experience, when someone does have a stroke or a heart attack, the admitting team will usually order a lipid panel, is what it's called. These are serum lipid levels, and that will be exactly this. This is a serum lipid level. And that will help them kind of demonstrate that maybe poor diet was contributing to the event that they had involving their circulation. Obviously, lack of exercise and obesity. Obesity is kind of, I guess, like the combination of poor diet and lack of exercise all put you at risk for developing coronary artery disease. But those are all things that you can change. Things that you can't change are your race, So obviously, the highest incident of coronary artery disease is actually in white, middle-aged men. But after age 65, the risk for men and women equalize. And heart disease is the leading cause of death in women, just some factors. So middle-aged white men, highest risk category, especially if they have combined that non-modifiable risk factor with modifiable risk factors. Not good, right? So also people who have familial or genetic conditions, I have friends that have high blood pressure at the age of 16 because it's just familial and they're on medication for it, and they're like sports stars working out all the time. It's just like something they were born with. There actually is something called familial hypercholesterolemia, which is an autosomal dominant disorder where there's a mutation in the LDL receptor gene, which basically means you have high LDL for life. It doesn't matter what you do, you're always going to have a high LDL. So in addition to that, we kind of talked about how men are more at risk than women until age 65, and then middle-aged white men are most at risk for coronary artery disease. There's some other things that put you at risk, like having a type A personality, stress, depression, high blood levels of a hormone called or a substance called homocysteine. So high levels of homocysteine can lead to endothelial damage and can start that process of coronary artery disease. So you want to ask about like a family history of heart disease, and then kind of assess the patient's diet and exercise when you're trying to see who's at risk for developing coronary artery disease. So how would someone who has coronary artery disease manifest? What sort of signs objectively are they going to show, and what sort of kind of subjective symptoms are they going to report? Well, usually they really don't have any symptoms. Coronary artery disease can develop in individuals much like hypertension develops without them knowing. They're going to be mostly asymptomatic. You're not going to really feel as cholesterol and fat and plaque builds up inside of your arteries. You don't really necessarily have any symptoms for a fatty streak, right? But what you would feel is the collective effects of coronary artery disease beginning to set in. And by effects, I mean the effect of your heart not getting enough oxygen because it's not getting enough blood, and blood carries oxygen, right? Remember, whenever you're thinking through a problem, you just got to go back to basics. So what does occur is something called angina, which is a fancy word for chest pain. Angina is, in textbook terms, the clinical manifestation of reversible myocardial ischemia, which is caused by either the heart needing more oxygen or not having enough oxygen. Increased oxygen demands are usually the result of a narrowed artery, like in coronary artery disease. And for angina to occur, the artery is usually about 75% blocked or more. What's occurring on a cellular level is that since the myocardial cells do not have oxygen, they're turning to, like I mentioned earlier, anaerobic methods and means to produce energy, and a byproduct of anaerobic production is lactic acid, which is damaging when you work out a lot and your muscles burn. That's because your muscles have produced lactic acid. This lactic acid irritates the nerve fibers and sends a pain signal throughout the upper thoracic posterior nerve roots, which is why even before you started nursing school, you might have been aware that the signs and symptoms of a heart attack are chest pain and left arm pain, right? Well, that's why. Because pain can be referred to the other areas of the upper body by irritation of that thoracic posterior nerve: shoulder, arm pain, back pain, neck pain. So there's different types of angina that indicate different types of levels of acuity or etiological causes, okay? So silent angina or silent ischemia has no symptoms. Easy peasy, good to start. Why is it important? Well, because it's most common in diabetic patients. I don't know if you've covered diabetes yet, but a side effect of diabetes is neuropathy. So if they have neuropathy, those nerve roots will not be irritated, or they won't feel that irritation, and therefore they will have no symptoms. So very important to understand that those with diabetes are at risk for developing events and not really knowing about it. The most common type of angina is something called chronic angina or chronic stable angina. This occurs intermittently and same symptoms each time. Okay? It's usually not a sharp or stabbing pain, but a pressing or a suffocating pain, sometimes even burning. And it can occur in those different areas. Now, chronic angina can be brought on by many factors, like physical exertion would cause an increased workload to the heart and could cause chest pain. Temperature extremes could cause vasoconstriction or dilation, resulting in an exacerbation of arteries that already are not receiving a lot of blood. And a weird thing is consumption of heavy metals can result in blood being diverted to the GI tract during digestion, which can cause chest pain. Sexual activity, similar to physical exertion, can cause it. So can changes in the circadian rhythm. Pain does not last very long, right? About 5 to 15 minutes. And it is not at rest. It is pain with exertion. Pain at rest is unusual. Okay? These patients know they have angina. They know when it's occurring. They have a specific medication that we'll go over that they take to prevent it from occurring, or when they know that they're at risk for it occurring. It is chronic. It is stable. It is not an emergency. Chronic, stable angina in patients with coronary artery disease. Now, acute angina, the big thing to understand is it is at rest. Okay? New, it's different, right? Or it's an exacerbation of the same. And that is an emergency. If it's pain that's occurring at rest, that's a problem. Or pain that does not. So what they'll do is they'll take 3 pills every 5 minutes called nitroglycerin, which we'll talk about. And if they still have pain, they are informed to call 911, because that could be an acute angina, and they could be having, a plaque could have ruptured, and they might be having a heart attack. So acute angina, or new angina, right, occurs at rest. There's also nocturnal angina. So nocturnal angina occurs only at night, not when lying down. Angina that occurs while lying down is called angina decubitus, and it's usually relieved by standing up. There's also a strange type of angina called Prismatal's angina. So it does occur at rest, but it's usually the result of spasms of major coronary artery. So strangely enough, it's seen in patients with a history of migraines, and it's not usually precipitated by an increased physical exertion, but it can be due to increased intracellular calcium. So they can treat it with calcium channel blockers. It can occur when you have a history of coronary artery disease, but not always. So they can have something that we're going to talk about, which is an ST elevation when pain is occurring, but then it would go away. So it's very strange, very rare. You might not even get any test questions on it. I wouldn't be too concerned, but you might get one. So it's important to understand that difference. And there is one more that we actually have to write in. We'll write in over here. It is microvascular microvascular, okay? Microvascular angina occurs in the absence of significant coronary artery disease, and it occurs more often in women and is brought about by ADLs as opposed to general physical exertion. That's just something that you should understand. It occurs in the really small blood vessels. So these are the types of angina that can occur, and the big thing to understand is the difference between acute and chronic. That's massive. So memorize these signs of chronic, and then if anything changes, it's acute, and that's really good to understand. So now we're going to talk about diagnostics and lab values, right? Those are signs and symptoms. If a patient is complaining of chest pain, you will hook them up to what is called a 12-lead EKG right away. In the emergency department, we have a timer on this. When someone signs in with chest pain, we need to have an EKG within 10 minutes of arrival, or else we fall out. And that's kind of a issue. Sometimes it's hard to do that, but it's something that emergency departments are responsible for, especially if we're an accredited chest pain center. And the reason for this will be made clearer when we talk about interventions. But when someone has chest pain, the first thing to do is to get a 12-lead EKG. You don't even, in the emergency department, we don't even need a doctor's order for it. We just do it. We have something called initiation of care orders, and if someone has certain symptoms, we can just start stuff. We just have standard order sets that have been approved by the medical team. But if you're on the floor, someone has a chest pain, just grab an EKG. It's not invasive, you're just putting leads on their chest, following the pattern of the heart and on the arms and the legs, and you have to get that picture, And this isn't going to be an EKG class, right? Because there's 12 leads in the EKG, and going over all of them, and you'll see elevations and depressions and inversions and the development of new waveforms and all of that, and that can be a different video. But you need to understand basic EKG anatomy to understand what the problem is and what you're looking for with a chest pain EKG. So for an EKG, this is what a standard heartbeat looks like on an EKG. You have your P wave, you have your QRS complex, and you have your T wave. Boom, P, QRS, T. So what you're looking for in this scenario is something called an ST segment elevation. This is where this latter portion of the heart that's represented on an EKG, the portion that stands between the QRS is for ventricular depolarization and the T is for ventricular repolarization, is elevated. So as you can see, right, like this portion here, this portion here, this portion here, this portion here are all, I didn't have a ruler, but they're all equal, right? We're just gonna pretend they're all equal. They're on something called the isoelectric point. They're all on the same plane, right? An ST segment elevation is where this portion, so you have your S and you have your T. So this area in between would not be on the isoelectric line. It would actually be, we'll use a different color, it would be elevated. That would be a problem. That is called that means they're having something called a STEMI. STEMI, like this, stands for ST segment elevation myocardial infarction. Bad news, heart attack, right? Dangerous. So that's why we get a 12-lead EKG, to look for an ST segment elevation. And then the other thing that we'll do real quick, just under labs, is the main value that we're looking for is something called troponin. Troponin is a normal part of heart cells, but when your heart is damaged by not receiving enough oxygen, they release a normal level. in my facility a normal troponin? Well, we have two ways of measuring troponin. So because heart attacks are so important and timing is so important, we actually have machines where we can run testing for troponin at the bedside without sending it to the lab. And for that, it's supposed to be less than 0.08. And then I think for the lab send down, it's less than 0.012. But anyway, troponin should not be elevated. The only case where you can see elevated troponin and not be worried is in someone who is on dialysis or has end-stage renal disease. And that is because they have decreased ability to filter that troponin out of their blood because their kidneys are impaired. They will not have a massively elevated troponin. They'll be like a few points above the normal high limit. So troponin should not be elevated in a normal person, right? If someone is having chest pain, you're going to check troponin initially. You're going to check it at the 3-hour mark, and in some cases you're going to check it at they're drawn in threes always. Initially 3-hour, 6-hour, right? This is because it might take some time, right? If they have chest pain initially, their troponin might be normal because it might have not reached the bloodstream yet, right? But if you check it at the 3-hour mark and it raises or it's slightly bumped and then it is really high, that's how you know they're having damage, okay? If the EKG does not show any changes, no ST segment elevation, but high troponin, so high trop, norm EKG, what's going on? It's called an N-STEMI, which is a non-ST segment elevation myocardial infarction. So there's STEMIs, there's N-STEMIs. In my experience, N-STEMIs are managed in the hospital with heparin infusions to help your body, intravenous blood thinners to treat the blood clot. In STEMIs, you go to the cath lab for intervention. So that's the main difference. And that's pretty much troponin, only lab value you got to know. Troponin drawn at 1 hour, 3 hour, 6 hours. ST segment elevation, main diagnostic you need to know. That's the most important thing to understand. So now we're going to talk about how to fix it. How would we, as nurses, in collaboration with the medical team, treat somebody who has coronary artery disease, right? So I want to start off by saying, we're going to go over pharmacology here. But first, as nurses, we are always focused on health promotion and disease prevention. You can identify, in whatever setting you're in, patients that you believe from your familiarity with their medical history have non-modifiable or modifiable risk factors for developing coronary artery disease. After you develop patients that are at risk, you want to educate them on the importance of changing their modifiable risk factors so that they don't exacerbate any of their non-modifiable risk factors. So this can include information on diet, exercise, smoking cessation. So you want to make sure you educate them as well on any testing or procedures we're going to be doing. And for a large number of cardiac tests that they need, they're going to have to be NPO. And believe it or not, that's something that patients really care about, is if they can't eat. So an intervention that is applicable to any disease process is education, health promotion, disease prevention, right? That's where it all starts. We want to prevent this from happening. We don't want them to even need medications. So that is important to understand. But talking about medications, there's a variety of drugs that can be used for those with coronary artery disease. The most important one is nitroglycerin, also abbreviated NTG, which can be given a lot of different ways. There's nitroglycerin sprays for acute pulmonary edema. There is a nitroglycerin infusion, which we went over in the last video. But for those with chronic stable angina, which occurs because of, again, the oxygen demand of the heart is increased and they have coronary artery disease, They can take it sublingually. It's usually given in 0.3 or 0.4 milligram tablets. And these are sublingual tablets, which means they're placed underneath the tongue. And they can take this for 1 up to 3 doses, 3 to 5 minutes apart. It's not wrong for these patients to take a dose prophylactically before exertional activity. There's also a nitroglycerin paste, which you might give to patients who are exhibiting signs of usually heart failure. With nitroglycerin paste, you put out 1 inch on a piece of paper and stick it on their chest. Make sure you date and time it. Put your initials on it when you put it on their chest. And it's very important that you do not touch the nitroglycerin paste without gloves on, because it is absorbed through the skin. And you are somebody who, I'm assuming, probably, maybe you do, maybe you don't, but if you don't have coronary artery disease and you don't have hypertension, and you have a normal blood pressure or a low blood pressure normally, and you take something that's topically absorbed that will cause hypotension, you can pass out. So that is important to understand. And then our little diagram right here is just demonstrating that a main side effect of sublingual nitroglycerin is a headache. Nitroglycerin is a vasodilator, so it helps by opening up the blood vessels to allow more blood to go through and more oxygen to go through to your heart. But it also opens blood vessels in other areas. It's not just selective for the heart. So it can open up the blood vessels that leads to your brain and cause more blood to rush into your head, giving you a headache. So you can give Tylenol to help with that usually, as long as they order it. So it's important to make sure they understand that and have a, no pun intended, heads up that they might be having a headache. Other medications that are used for coronary artery disease is Plavix, also called clopidogrel or aspirin. So these medications are antiplatelets, so they prevent those platelets from aggregating onto the lipid deposits. Remember we talked about how like damage can occur and then the clotting cascade happens? These prevent that from happening. And that's what this diagram is supposed to be. It's supposed to be like that's the plaque, and then this is when it could potentially rupture. So it prevents platelet aggregation. Or also when they have stents placed, if they do have this happen without it, then they need to be on usually dual antiplatelet therapy. It's important that they understand that these medications should be, they need to tell all of their providers that they're on this, because if they have to have any sort of procedure done, they need to stop these medications for about 5 to 7 days. The main cause of coronary artery disease is high levels of cholesterol. So medications that reduce cholesterol would be indicated. And this class of medications is referred to as statins. So your cholesterol is made in your liver. And, there's something called HMG-CoA, and that is converted into mevalonate, which goes through a whole cascade and is then eventually made into cholesterol. So statins they are HMG-CoA inhibitors. They prevent that from converting into mevalonate. So they interrupt cholesterol production in the liver to help lower cholesterol. An important thing to understand is that patients should not just take their statin, like a atorvastatin or prasuvastatin or rosuvastatin, and stop lifestyle changes. They want to continue lifestyle changes and also take statins. It is not a substitute for. So you can start to see, first off, liver cholesterol production usually occurs at night when your body is not digesting food. So some of these need to be taken or are usually taken at night. With newer medications, it's not really an issue anymore. And there's been some clinical studies done to see if that's truly the case for all statins, and it's not. But sometimes that's good, because if patients can only take something at night, they might not be prone to. Some people might work night shift, they don't want to take it, or they forget about it at night. So important to understand that. But usually you take them at night, and something to monitor is increased LFTs, which would be a sign of liver impairment because they're working in the liver. So sometimes they'll stop it if it gets to an unsafe level. And then obviously these patients are usually on beta blockers, calcium channel blockers, ACE inhibitors to reduce the overall workload of the heart and thereby the myocardial oxygen demands. So now we're going to talk about the procedures that can be done in somebody who's having coronary artery disease. So there's something called a cardiac catheterization. Cardiac catheterization is where they go in through your groin, usually is where they access it, and they insert a needle into your circulation that leads up to your heart, and they're able to see your coronary circulation and identify any blockage and how bad the blockage is. If they see a blockage, they can do something called PCI, which is percutaneous coronary intervention. And this is all done in a place in the hospital called the cath lab. So this is a specially, developed area of the hospital with special trained staff to perform these procedures. So you can have a cardiac cath done and not necessarily have a STEMI, right? It can be something that's scheduled, and you can have, if you have significant stenosis and they want to prevent you from having any sort of issues. But if somebody's having a STEMI in the emergency department, then we will call a code PCI to let the cath lab know that there's someone who emergently needs a cardiac catheterization and PCI performed, because the STEMI is proving that there is a definite blockage and it needs to be addressed immediately because their heart's losing oxygen. So in this procedure, like I said, they go in usually through the groin and they go up into the heart, and the blockage is located, and then a catheter is this catheter, right? And this is the artery that has a lot of significant stenosis from plaque buildup, places a stent in there, and the stent can then be expanded, as you can see here, therefore pushing that plaque all up. And the stent kind of perfuses the area and it lets blood get through again. So patients who undergo this procedure, PCI, need to be on dual antiplatelet therapy for about a year until the smooth vascular surface around here returns and the stents heal. So when they're done this procedure, because they're going in through the femoral artery, the patients will usually have a pressure dressing to the area and not be able to bend their move their legs or sit up above a certain angled degrees for a period of time. And you also want to make sure that whichever leg they went through, you're assessing the neurovascular status, the pulse, the cap refill, the sensation, the strength of that extremity, so that you can assure everything is healing the way it's supposed to do. It's supposed to be healing. So then finally, we're going to talk about what could go wrong. And the worst case scenario in coronary artery disease is something called acute coronary syndrome. So this happens when, that ischemia, that decreased blood flow because of plaque buildup is left untreated. So a plaque that wasn't causing any issues, normal plaque here, ruptures. That's what that's supposed to be a demonstration of. Causing, and I mentioned this before, we kind of talked about this, causing a clotting cascade and a bunch of a thrombus formation because a bunch of platelets are aggregating there, and that is making it really complicated and this whole big mess, and then that is causing a lesion that's going to rupture, and then if fully blocked is causing an ST segment elevation. If it's not fully blocked, it's causing an NSTEMI or unstable angina. So this is the danger. This isn't a heart attack, myocardial infarction, which we can do in a separate review video, but untreated coronary artery disease can almost spontaneously lead to a myocardial infarction or ACS. And that's what could go wrong. That's the worst case scenario. Thank you guys for tuning in to this episode of Mr. Nurse Prep. Hopefully this helped you in your understanding of coronary artery disease. Please like and comment if this video was helpful, and feel free to subscribe for more content. Wishing you best of luck in your studying for the NCLEX or your nursing lecture exams. And let me know in the comments what other videos you'd like to see. Thank you.